what I wanted to do is get started with our first speaker. Her name is Virginia Ramachandran. Perfect. Virginia has quite an extensive resume. She obtained her Bachelor of Social Worker at Wayne State University, Master of Social Work at Wayne State University, Doctor of Audiology at Wayne State University, and a PhD in audiology. PhD audiology at Wayne State. She currently is Wayne State University's Department of Communication Sciences and Disorders adjunct assistant professor, and she is also the head of audiology at Otakon. And she's the past president, board of directors of the American Academy of Audiology. So let's give a warm welcome to Virginia.
Thank you. Thank you very much. Hello, good evening. So I do have a few disclosures. As you can see here, I work for Otakon and therefore receive a salary. I am an author and editor for Plural Publishing, so I have some financial interests there. And I'm not currently teaching at the moment, but our adjunct faculty for Wayne State. So I wanted to be talking this evening about person-centered treatment planning. And this is kind of a topic that's been of interest to us at Otakon for a long time. Some of you may be familiar with the IDA Institute that was funded by the William Demott Foundation at its startup. In the very recent past here, IDA has had to actually close its doors, unfortunately. But our goal is to make sure that person-centered care remains front and center. And so that was one of my objectives this evening, is to make sure that we continue on that tradition, because this is really the heart of what we do. I assume that most of you who are here are interested in a few things. One is to make a good professional living for yourself, but also that you want to help people with hearing loss and their families and so on. And I hope that the latter is true, because if it's not, you're probably in the wrong field, because there are a lot better ways to make money than to try to sell something that nobody wants to old people and children, right? So we're here because we want people to be successful. We want people to have what they're looking for out of life. So the question that I have is really about, as I'm an audiologist and as hearing care providers, how important is the care that we're providing to people? And that can be really difficult to put, to really quantify, right? How important the care is that we provide. So when people, you talk to lay people all the time who talk about getting hearing aids, and they're thinking about this as a device, right? They're not necessarily thinking about the care component. And the question really becomes, though, how important is that care? So I'm going to share a research study that was conducted a few years ago. This was actually in 2017, so it's getting on in years now, but I think it was still really important. And it was very important at the time, because this was prior to the advent of over-the-counter hearing aids. So this study came from Indiana University, and it was on the effect of service delivery model and purchase price on hearing aid outcomes in older adults, a randomized, double-blinded, placebo-controlled clinical trial. So if you pay attention to research at all, this is all of these are really good words that you want to have in a research study, right? That it was randomized, blinded, placebo was in there, and so on. You can find this if you want to read it yourself. It's an open source article, and it was paid for by your tax dollars, which is why it's open source. So we all paid for this, and because we did, NIDCD, National Institute of Deafness and Communication Disorders, actually publicized this as an NIDCD-funded study on their website. And their take on the outcomes of this study are what you see here. So this was a screenshot from the website. A model approach for over-the-counter hearing aids suggests benefits similar to full service purchase. And when they are saying full service, what they're talking about is the service component is the professional care that we're providing. And so the government's takeaway of this was that this model for OTC had the same types of outcomes in terms of benefits for the patient. And so I want to actually take a really close look at this. And there were a few different things that you can see that they looked at. They looked at the service delivery model, so that was sort of OTC versus whether they were fit by an audiologist. They also looked at purchase price, and so for the sake of time, I'm going to tell you purchase price didn't matter. It didn't matter whether they were paying $300 or $3,000. Outcomes were exactly the same. And then there was a placebo-controlled component here where people were fit with devices but didn't have gain associated with those devices. The good news is that amplification works. Hearing aids and gain made a big difference. But that said, there was actually a component of the placebo group where they got some benefit. It was a little bit confusing. So part of that placebo-controlled aspect you could chalk up to some of the care that's provided. But also they left the directional microphones on at the beginning of the experiment. So about halfway through, they realized that these patients who were using the placebo group actually had their directional mics on. And so when they did a connected speech test, they started doing better than they would have expected. And they realized, uh-oh, there's actually some benefit just from the directional microphones, even though it was transparent gain. And so they turned them off for the rest, but it's not exactly a very clean placebo group. But so we're going to just take that out for now, but suffice it to say hearing aids did work, which was great. So really what we want to focus on was, how was this model of care? Patient fit themselves or they were fit by the audiologist. And the way that you can understand that then is to use the exact same devices for both groups, and that's what was done here. So the technology was neutral. They actually used a pair of resound hearing aids for all the subjects, and so it was the same set of devices, whether they were fit by themselves or they were fit by the audiologist. So let's examine, though, before we get into it, I just want to, before we get too far, talk about some of the assumptions about this model approach for OTC hearing aids. First off, there's the subject pool. So these subjects, their inclusion criteria included being age 55 to 79, English as a first language. They had a mini mental status exam score of greater than 25, so they were screened. They had no prior hearing aid experience, and they did, in fact, have a mild to moderate sensorineural, age-related symmetric hearing loss. They were excluded if they had medically treatable ear conditions, flat tims, progressive fluctuating hearing loss, cognitive, medical, language-based conditions, taking any ototoxic medications, had Meniere's disease or multiple sclerosis, wouldn't waive a medical evaluation, or unwillingness to be randomly assigned to the groups. Just like all of your patients, right? So I joke because, of course, we see all of those patients on a daily basis. But there's also the idea that you've screened a group of people to say, yeah, actually you are candidates for over-the-counter hearing aids, or at least as they were intended to be according to what the legislation was saying, that this is a perceived mild to moderate hearing loss. It turns out, interestingly, that when you look at the initial subject pool, people who responded to the request for subjects, like an ad was placed in the paper and they said, yes, I fit this criteria and I would like to participate. Of those, it was 323 people. 42% of them did not meet the eligibility criteria. And in general, it was because of their hearing loss. So there was something about that exclusion criteria versus the inclusion criteria where they didn't meet that. And what's fascinating is every study that I've seen so far where people are like self-identifying as over-the-counter hearing aid users have about the same rate of people who do not qualify for the study according to the criteria. So I think this is a really interesting study in that it gave us some of the initial data, which has been verified since then, that about 40% of people can't self-identify as being appropriate candidates for who OTC hearing aids were intended to treat. But at any rate, this group that they did, in fact, verified that, yes, they were the appropriate candidates for OTC hearing aids. So these are the group of people that, sort of, again, the legislation had in mind there. So of those who enrolled, when they looked at the final group, 98% were white, 78% had a college degree, and the median education level was a master's degree. Yeah, and 80% had an annual income over $45,000. Again, just like all of your patients, right? Not so much. But what my point being here is that this is a really highly educated, capable group of people who are in this study. So when you think about the group of people who OTCs might be intended for, it's not meant to be limited to just this group of people. It's meant to be a broader group of people. So when we look at the results and the outcomes, it's something to be thinking about in terms of what ends up happening. So how they went about doing this, they put these folks into two groups based on randomization. The audiology best practices group, they had the audiologists select the dome size and tubing length. They took the hearing aids and they programmed them according to this protocol, so they were fit to NAL and L2. This was verified. And then they turned a bunch of the hearing aid features off. This is super common in hearing aid research, and when you go to read hearing aid research, this is something that you should be looking at because it happens in the vast majority of cases when research is conducted in an academic setting that they just turn off a whole bunch of the advanced features. I'm not quite sure why. There's always some comment about like making sure that there's some equivalency, but it really kind of gets away from them. Well, what was the point of getting the advanced technology, right? It takes away a lot of that benefit. But at any rate, this is pretty consistent with what's in the academic literature. So that's how they programmed the hearing aids. They did loudness discomfort level adjustments. They provided an orientation, provided them with some communication strategies, counseling, written instructions, and they could receive support as needed. In that consumer decides group, that OTC model group, the patient watched a video of instructions, selected their own dome length and tubing, selected from a variety of hearing aids, but they were all the same hearing aids that were programmed the same way. It was really about the color that they could choose. And then they had 3 programs that were pre-programmed in the hearing aid based on very common audiometric configurations. And they could just choose which of those configurations was most comfortable for them and that they preferred. The hearing aids were otherwise programmed the same as the audiology group. They received written instructions and, interestingly, could receive support as needed. You know, like an OTC model. They could walk into the university clinic at any time and receive support just like the audiologist fit group. And they did. They accessed care at the same rate as the group that was fit by the audiologist. So this was part of the results. So it's kind of an interesting question about whether or not this was actually a model for OTC hearing aids, but it predated the legislation and so on. So this was what they were envisioning at the moment. All right, so what were the results of this? There were a couple of really good results about the audiology best practices group. They were better than the consumer-directed group when it came to a couple of the hearing aid satisfaction scales of hearing aid features and dispenser-related processes, which is, again, a good thing, right? That the dispenser-related processes were better when they had a dispenser versus not, right? So that was to be expected. But where the NIDCD got their sort of, the benefits were the same, was from everything else. Because when you looked at the results, there were no differences on a whole bunch of the subscales for, this wasn't the AFAB, but this was the full version, and then connected speech test, HHIE, and whether they used the hearing aids. And so that was the big takeaway, was that there were no differences and patients could fit themselves just fine. They did ask one other question, which was not really prominently featured in the article, but it was in there in the results section. And at the end of the study, they did say, do you want to keep these hearing aids? 81% of the group that was fit by the audiologist said yes. 55% of the group that was fit by themselves said yes. Yeah. So there was something about what the audiologist had done that contributed to their benefit. And when I say benefit, I mean benefit, because in the article it said that the most frequently cited reason for not keeping them was lack of benefit. which struck me because the NIDCD website really explicitly stated that these were benefits similar to full service purchase. And I would argue that it's clearly in the data that that was not the case. Now, they actually, because if they were being good ethical researchers, they asked that group who were fit by themselves or who had fit themselves, do you want to be refit by the audiologist? And I want to emphasize that this was the same set of hearing aids, programmed the same way. And when they were refit by the audiologist, 83% of them wanted to keep the devices, okay? So I think that this has a really important, something really important to say about the value of care that's being provided. The only other thing that was different here was that real ear measures were done. And so there is some audibility component, but I don't think we can chalk up a huge difference of almost 20% wanting to keep the hearing aids just to doing real ear measures. I think that the relationship that the audiologist had and developed with the patient was actually making part of the difference here at the very least. So the question of how important is the care that you provide, it can matter. It absolutely can matter. The question is, and we have evidence for this, right? And the question, though, that you have to ask yourself from an introspection point of view is, does your care matter, right? You know, if somebody comes to you versus fitting themselves, are they going to have the same type of result that those clinicians had when they were being fit in that university clinic, right? Do you have the same amount of time and everything? And there are a couple of sort of follow-up questions that I would just like to kind of throw out there as food for thought, because it's a good opportunity every once in a while for all of us to kind of step back and go, okay, where am I, right? So, you know, when it comes to the question of does your care matter, we all absolutely feel that it does, I think, or else, again, we wouldn't be doing this. But a few follow-up questions that your patients might want to know, or other providers who are referring to you might want to know, or third-party payers or whoever's paying for the devices might want to know, right? Which is, hey, do you know, and can you prove it, that your care matters, right? Because that is the bulk of what your patients are paying for, actually, when you are dispensing hearing aids and when they are paying for hearing aids. And along those same lines, can you explain to people what your approach to care is? Is it unique from other people or from other retailers, for example, who might be in your neighborhood? How much is the cost of your care compared to your cost of goods? In some cases, you know, even if you had cost of goods for free, you know, how much would you be charging for your services, right? And does that make sense to your patients? And then, you know, with the people that you contract with in terms of payers and so on, are there any challenges with that where they're interrupting that process? And, you know, is that something we need to be thinking about? So, you know, all of these are important for the people who, again, are accessing the care and referring to you and so on. And it is so important, right, that we are able to demonstrate the value of what we're doing. When you have that satisfied patient, it's going to matter to them personally, but it's also going to matter to your practice, that you're going to be able to have people coming in because they understand that you're a good provider. They understand that they're going to get value from you as a clinician. But it is kind of an interesting question. We know that when people are satisfied, that's a practice builder. But do patients really care about care? It's hard to know because they don't think about what we're doing as providing care per se in a lot of cases. They think about what we're doing as giving them hearing aids. And sometimes they think about service associated with it, but they're not necessarily thinking about it as in the context of professional care. And so how they think about the relative cost of that becomes kind of an interesting thing. There was a recent article that was published, I think it was just a few weeks ago, in the AJA. Anna Gilla, who is a wonderful young woman researcher in Texas at Lamar, she looked at the benefit cost analysis of hearing aids, OTCs, and hearing care services. And they looked at a group of, across several different clinical sites, of patients who were previously fit with hearing aids. So these were people who received care, received prescription hearing aids, and so these are current users. And this is a different group than when you're asking non-users, right? So that's a very different situation. So, people who've experienced this, what do they think about it? How much are they willing to pay? So one of the really interesting things about that group of people who've gone through and experienced care, when you ask them about their willingness to pay for over-the-counter devices, the median response was $0. You can't give them away to these folks because they have experienced care. So they do know that there's something different, okay? So that was a really fascinating experience here. But what were they willing to pay? And when it comes to the devices, and they call it ADT, Advanced Digital Technology, when it came to the devices, the median was $1,500 when it came down to it, because it's really somewhere between $1,000 and $2,000 there. That's how much they were willing to pay per ear for for prescription hearing devices. Okay. But when they asked them about the service or the care associated with that, the median willingness to pay was $250. Now, the challenge here is, did they really explicitly understand that they were paying for care alongside the hearing aids, right? Because what they've reported as their willingness to pay was probably around what they did pay. Right? So they probably paid around $4,500 or so for the devices and the care bundled together. And so that's what they perceive the value of the devices to be, because they don't necessarily explicitly separate those things out into this. They might have even been thinking about the care as follow-up care, for example, right? So these other things when they come in. We just don't know what they were thinking, but I think that there's an issue where our patients simply don't know how we're thinking about the care and the relative value of the care to the devices compared to how they're thinking about it. They're thinking about it all as one thing, and that you're providing a service, but it's not necessarily separate from the hearing aids. So I do think that patients care about care, but they don't care about it until they do, right? So if you ask that question to somebody who hasn't had the care, who hasn't had the experience of getting hearing aids, they might have a very different answer, because they really don't know what it takes to be successful with devices, right? And frankly, when they do care, do they really know it when they see it, right? Do they understand what it is that they're paying for when it comes to the care versus the devices themselves? And I think that there is a big misunderstanding there. And I know we can all say, and we do all the time, go, well, we did it to ourselves. But I would say that we do it to ourselves every single day, right? Because we're not explicit with our patients about what it is that we're doing from a value point of view for the care versus what the devices are doing and what the role of the devices is relative to what we're doing. So I think that we have to become more comfortable being very straightforward and explicit and explaining to people what it is that we're doing for them and why they should be choosing us as providers. And so I'm going to kind of walk through some steps about how we might be able to do that a little bit better and some ideas. But everybody will have had their own experiences with this. And so if you are doing this every single day, that is amazing. I would love it if you could share your thoughts and ideas with other people. And if there's any one piece of this that could be helpful in establishing your ability to share with your patients how you are different, how you're unique, and the value that you're bringing to them, that's what I'm hoping you might get out of this. So the first thing is to have a philosophy of care that you can describe. And that's not easy to do. Hopefully your practice has some kind of mission statement or just something that you can use to talk to patients about what your model of care is. If you don't, I would strongly encourage you to do that and it needs to be something that really matters to you. I recently went to a new dentist, and they were all about the practice. They were amazing. I thought it was great. I was very impressed by the level of care that they provided, but it was really interesting because it was all about them. It wasn't about me. It was about what they were going to bring to me, but it wasn't really about what I was looking for or anything. So it's kind of an interesting thing. You can really have a philosophy of care that is above and beyond what others might provide, but at the same time, you also want to be careful that it's not just about you and what you are providing so much as is it meeting the needs of what that person is providing or is expecting and needing. So that was kind of an interesting experience for me to go, I believe that you guys know what you're doing. I believe that you care about the quality of your practice. I believe that you care about your reputation. Not 100% sure that you care about me, but you're better than most of the people in my neighborhood, so I'll go with that. So I'm going to keep going there. But wouldn't it be cool to find somebody where I did feel that connection? And so far, I haven't gotten that from my dental care yet, But one way to go about creating that relationship is through a concept of person-centered care. This is very commonly talked about in the medical field, not necessarily commonly practiced. Some areas of medicine and healthcare are much better at person-centered care than others. So some really do go in and embrace it. Some are very good about, and it's really kind of these niche areas. Like some of you work with ENTs, like where head and neck cancer is a thing, right? And there'll be some aspects of it, right, where they're really good at going in and thinking about what the patient wants and what the family wants. But in general, you don't see a lot of this in medicine. There's a lot of thought about it. People want to see it, but there's just it's not really something that they practice day to day. I would say that audiologists are probably, and dispensers are probably better at this than most people. They're spending more time with the patients. They tend to, if you're in a clinic where in a hospital setting, your department probably has the best scores in the health system because you spend more time with your patients, you listen to them more than most people, but there's always room for improvement, right? So I think we're pretty good at this relative to other healthcare providers, but we can always be better. So the idea of person-centered care is that people are equal and active partners in the management of their hearing difficulties, and it's designed around the individual. So you're respecting their preferences involving family where appropriate, and other communication partners, and it's shared decision-making and goal setting. And so some of the elements of this, sort of the tactics to get there, are active listening, open-ended questions, empathy, shared goal setting and decision-making, which is partly what I'm going to be talking about here, involving family and friends, again, where appropriate, and understanding individual preferences. So everybody always talks about family and friends, and I get that, but again, I think it's a where appropriate kind of thing, because everybody's family dynamics are different, right? So it's really, if there's somebody that you care about that you want to have as part of this, then that's awesome. But we've all seen certain relationships where, because people are coming to us with a communication disorder, that has oftentimes spilled over into a relationship disorder, right? And so I think we're in a different place a little bit than the rest of medicine when it comes to person-centered care. Because sometimes when people are coming in, there might be a punitive component to this, and somebody kind of forcing the issue and so on upon somebody else. And so we do want to make sure that we give them space to understand that they're in charge of their own care. The family is a huge part of that dynamic, but we do want them to have the space that they need to be able to talk about it, right? So I think that really a huge component of making all of this explicit, of making sure that we're meeting the needs of patients and engaging in this from a philosophical point of view, is to have a formalized treatment plan. And it could be a rhetorical question, I don't know. Is anybody doing a written formal treatment plan? I never did? No? Okay. We learned to do it, if you're an audiologist, you learned to do it when you were taking those speech language pathology courses, right? Yeah. And other areas of medicine, they do create a treatment plan, and this is what our goals are, and this is what we're going to do. And I really am a strong believer at this point in my life of doing this with patients for a variety of reasons, but not the least of which is to differentiate yourself from your competitors, to make explicit what it is you're doing for patients, showing them the value of the care that you're providing, and you're going to have better outcomes and a whole bunch of other important benefits, which I'll talk about a little bit more at the end. So first off is, just the fact that you have a treatment plan is your strategy, right? You're going to have a strategy to get there. And there's a whole bunch of other tactics that you can do along the way to support that strategy, and you should do some of these things, and you've learned a lot about all these things, like motivational interviewing and demoing hearing aids and doing all sorts of other things. Those are tactics to get us to where we want to be. But the treatment plan is the actual strategy. Like, what is it that we're trying to achieve, and how are we going to get there? That's the strategy that I'm talking about. And so if it's not something that you've worked with a lot before, we do have some tools that we've recently developed from Otakon, and I'm hoping they're here. I think we do have them available at our booth, and if it's something that you're interested in, we're happy to send them to you for those of you online. But we wanted to try to help people understand, just at a very general level, what it is that the process that they're about to go through looks like, right? And so this is a very generic overview of what care looks like. Just sort of that we're going to do an evaluation. I'm going to help you understand what's going on here. We're going to fit the hearing aids. There's fine tuning. There's ongoing care. I work with whatever technology right? And so that's just one way to approach it. And so if you're completely not sure where to start, this is something that you could use. But I would encourage you to take something like that if you don't already have it for your practice and really customize it for yourself, right? And then you can really focus on the things that are most important to you in your practice. And you can start with, my philosophy is this, but I want to know what's most important to you, right? And so that we can understand what that treatment process is going to look like. So from a general treatment planning point of view, this is sort of the process. And so I'm going to kind of go through each of these steps and talk about some tactics that you can use within that. But it's really about setting up what that treatment plan is from the get-go that I think is the most important part. So just having that discussion and then setting up a process, I think is really the most important and critical component. So of course, the first step, diagnosis. And we love diagnosis, don't we? I mean, we're just all about it. It's so fun. It's the part that I enjoyed most about my job. It's critical that we get this part correct. But I think that one of the things that is most important, and if those of you who've been doing this for a long time, you already know this, right, is just let them tell their story first. What brings you in today? I think that level of open-ended question is the fastest way to get to where we want to be, right? Because otherwise, if we start off, and you guys have all seen students do this, you've been students who've done this, right, where you go through the checklist in your mind of all the things you want to ask. I had an experience when I was a social worker starting off. It was my very first patient out of school. I was working with my supervisor, and it was in an infant mental health clinic. And a child had been referred to us who was 4 years old, and she was about to get kicked out of kindergarten or preschool, as it were. And she was having trouble, and the doctor had referred her for a rule out of autism. Okay, and so we were sort of the first round of people who were working with her. And my supervisor, who was very experienced, was working with the child, and at the same time in the room, I was working with the mom. And I went through a huge checklist of developmental questions about this child. And like half an hour into the appointment, I said, well, what was it that made you take her to the doctor in the first place? And she said, well, she was doing weird things that she wasn't supposed to be doing, like she was turning on the microwave by looking at it, and she was making the keys float around when they weren't supposed to. Mom had very active, severe schizophrenia. And because of this, her daughter, who basically interacted with nobody else except for the times that she went to school, was echolalic, and displayed a whole bunch of self-stimulating behaviors that were very characteristic of autism. So I have wasted a whole lot of time on things that were really not all that important before I finally asked the right question of what are we trying to do here? What happened, right? And when somebody is coming in to see us, especially for the first time, something bad happened, right? As audiologists, nobody wants what we are selling. Nobody wants to see us. Nobody wants hearing aids. And so if they are seeing us and they're sitting in our office, it's because something bad happened that made them feel worse than not wanting hearing aids. And what they want from us is to take that bad thing away, take away that bad feeling. But we can't do that until we understand what it was, right? So we have to give them a minute to tell their story. And they might not be ready to tell that story at that exact moment, but we need to leave the door open for them to do that, right? Because we're going to get there faster if we just ask them the right question of, why are you here? Tell me what's going on, right? So we have to do that part, and then we have to get the diagnosis right. And there's two components to what we're doing, and that's always confusing because, when it comes to like billing and coding and all this stuff, it's funny because I having been on the AAA board and paying attention to like coding and CPT codes and all that, it's funny that Medicare and, frankly, the medical community doesn't quite understand the distinction that when we're doing a hearing test, we're looking at both. Right? We're looking at both medical disorder and hearing disorder and the communication disorder. And a whole bunch of the tests that we do relate to both, and some more to one than the other, but they only want to look at the medical component. They only want to pay us for the medical component, and they don't tend to want to pay us for the communication disorder component of it, even though what we're doing is for both. But we have to get both right, because if the hearing diagnosis isn't right, then we might miss something that could in fact be treated by elsewhere, right? Or we might just be kind of struggling with our fitting, because frankly, everything we know about hearing aids and fitting hearing aids is for typical hearing loss. And typical hearing loss, I mean mild to moderate, gently sloping, age-related, symmetric, mild to moderate sensorineural hearing loss, right? And pretty much all of the evidence that we have related to hearing aids, most studies exclude everybody else, right? And so if you're approaching the patient in front of you as if they're that typical patient, you might not be getting the results that you're expecting, right? And so we need to understand if it's Meniere's disease, if it's a third window syndrome, if it's something else, that we need to be thinking about, okay, what's the etiology? What could be potentially interacting with the treatment that I'm providing, right? So that's important. From a communication disorder perspective, I just have to give a little plug for ACT. Speech and noise testing is really helpful in understanding the communication disorder component of it. I mean, the audiograms actually, everybody kind of gives the audiogram a bad rap about like predicting communication function. Audibility, though, does matter, and so it's not irrelevant. I mean, the audibility does matter, but then above and beyond the audibility, there is still a qualitative component to how well a person can hear, particularly in noise. And so speech and noise testing is very beneficial just to understand that. Most recently, though, we have come out with the interacoustics, as well as several other GSI, MedRecs have come out with a new test, the audible contrast threshold test, which is using non-speech stimuli to try to predict speech and noise function. And the purpose of that is so that you can have a language-independent test, because that creates access for folks. It's pretty fast to do, and it's ensuring audibility. So the idea is that it's actually designed to predict aided speech and noise performance. What we've recently done with this is to incorporate the ACT score that somebody would get into the fitting software, because that is the other challenge with it. speech and noise testing can help you to understand whether or not somebody has a problem or how much of a problem they have, but it doesn't necessarily directly relate then to how am I going to program devices in order to support them. That was the point of integrating the ACT score, our ACT value, into our fitting software. So we've been able to do that with our most recent devices, past couple devices. So that is something that you could do and be thinking about, though. But regardless of how you do it, you want to do some type of super threshold measure for communication disorder if you're able to do that, because it does provide you with some additional information. And of course, once you have this diagnostic information, we want to be thinking about, when we relay this to the patient, what is the most important to them. And the person who developed these slides for me initially had this really lovely thing about how to talk about the audiogram, and I pulled it out. And the reason that I pulled it out is because the best thing that ever happened to me clinically was that we were forced to switch to a computer-based audiometer for some time when Epic came out in our medical system. And when that happened, the printer was down the hall at the end of ENT. And so if I wanted to get that audiogram, I would have had to walk down to ENT at the end of the hallway to grab the audiogram and bring it back. And I was one of those people, okay, so the bone conductor's on the patient. And in the past, I would have just gone in, taken the bone vibrator off, and talked about the results with them. And I'm like, well, I don't want to go in, take it off, then leave, then go get the thing, then come back. Like, that's a lot of time, right, in a busy clinic. So I just didn't use the audiogram. I'm like, it's too far away, and half the time the printer is not working anyway, right? And so I just went in and I said, yeah, you're right. You do have some hearing loss. It's more in some of those higher pitches. So what you're telling me about, not able to hear your wife as well, or these other things, like, yep, that's absolutely the case. And so let's talk about that. And if they were interested in, if they were having a communication disorder, if that was something that they were challenged with, then we could talk about treatment options. If it was something where that wasn't an issue, or they had normal hearing, we would send them on to ENT for whatever they came in with. But just going in and talking to them, like, yeah, because you know what? They don't care. They don't care at all. They don't even know what an audiogram is. They don't know what I was writing on. They don't care about left ear, right ear, X's and O's, or anything like that. I mean, and I was in Detroit. There were engineers all over the place. But unless I put that graph in front of them, they don't even know that it existed. Right? And so I could actually just go in and talk to them about what their symptoms were and validate what their experience was, to be perfectly honest, that was the best clinical move I ever made, was just throwing the audiogram out the window when it came to talking to patients. It was very useful to me, very useful to my colleagues. It was not really particularly useful to the patient. And when you take it away, it was like I didn't miss it at all. So. The other thing I think from a diagnostic perspective that is useful is helping people who are not typical understand that they are not typical, because they have no idea, right? Again, unless we tell them, you're actually not like everybody else. Your hearing is not common. They have no idea. And we know when we see that person with Meniere's disease, when we see that reverse slope hearing loss, when we see that asymmetry, I've seen audiograms that go like this, right? When you see something like that, you're like, oh my gosh, and this is going to be a hard fitting. Patient has no idea, right? And so we go to fit them, and it's a challenge for us because part of the reason that it's a challenge for us is we have not necessarily set appropriate expectations for them, right? And so for those people, I think it's really important that we set the expectation of it is you a little bit, right? Because sometimes it's them, right? And so I tell them, you're a unicorn. You're kind of unique, actually. Most people that I see don't have the type of hearing loss that you have. Most people I see don't have the type of challenges that you have. But I'm going to do my job of working really hard to get it right, because unfortunately, when you're a unicorn, and nobody wants to hear that from your provider, I get that. You don't want to hear that from me as a provider, but you are a little bit different than everybody else. Because of that, we don't necessarily have the same evidence base to work with. We don't necessarily have the same formulas to work with. but I'm going to work really hard to make sure that we get you what you need. We might not get there the first day, okay, but I will work with you until we do. Your job is to be patient and to make sure you're giving me really good feedback so that we can get you closer to where you need to be, right? And so if you can kind of set that expectation, and you might have to keep bringing it up again, right? Because their families might not know and so on, right? And so that's something that I think can be really useful too in terms of that diagnosis and treatment planning. Okay, so then the next bit, of course, I think is sort of the next really critical component. If they haven't, when they come in and tell you their story, if they haven't yet defined the problem, I think we need to keep digging for it. And they may have told you a lot, but there still might be a lot more that they need to tell you, and that's part of the problem. So there's this marketer, his name was Clayton Christensen back in the day, and he was pretty famous for this concept of jobs to be done. And so what would happen is he actually told a story from back in McDonald's, back in the early 80s, I think. And McDonald's wanted to sell more milkshakes. And so they went in and they took this focus group and they were like, what do you like about the milkshakes and how could we do it better? And they listened to them and made some suggestions and none of it made any difference. So instead, they tried to understand what job is the milkshake fulfilling for people. And they went and looked at data about people who were buying milkshakes, and it turned out that almost half of them at the time were buying them before 8:30 in the morning. And the reason that they were doing this, once they got down to actually talking to them about it, was because they had a long drive ahead of them for work, and they wanted something filling that they could actually be, keeping them busy at the same time. So it was sort of just engagement of and so some of us will take coffee, right, into work, right? So for them, though, this was the thing. Instead, they didn't want coffee, but they wanted something to do, and they wanted to be full, okay? And other things wouldn't necessarily fill that role for them. They wouldn't do the job. So they could take a bagel, but it was kind of messy and everything. They could eat a banana, but it went by too quickly. They could do all sorts of other things, and something might not keep them full. And so they actually thickened the milkshakes based upon this data, because it actually worked even better to help people with the job that the milkshake was trying to do, because it actually is so viscous that it took it longer for them to actually finish it. It was more filling in that way, and so on. So they actually designed the product around what the job was to be done for that milkshake. And it's a silly example, but I think it kind of helps us to understand that when somebody comes to see us, their goal is to hire us or the product that we're selling, or both, to do a job, right? And we need to really understand what that job is. And that job is not hearing better. Nobody cares about their hearing, right? Nobody wants hearing aids. So if they're coming to us, again, something has happened that made them want a solution. But that's what we need to understand is what's the job that we're trying to fill here? Communicating better is probably part of it, but there's also probably a part of it where I just want this person to stop nagging me. I just want this to go away. I just want this to happen. We need to understand what the just this is in order to actually fulfill their needs, right, and to do the job for them. And so I think if you kind of think about it some way, what's the job that we're trying to do here? And it could be a lot of different things. And I bet if you think about it, you have heard some actually crazy kind of things like that you would be like, you'd be surprised that this was the job that was needed to be done. I bet a whole bunch of you have had patients who come in right after their spouse died, right? The job to be done is to fill in this big hole that's a void, right, in some way, because that spouse was doing something that they needed them to do, probably, again, acting as a communication intermediary, right? But, we got to understand really what was going on there to get to the bottom of that. This is a this can be difficult, right? There could be emotions here. This could be a little difficult conversation. And we, people won't necessarily dive right in. Again, some people might, which is really interesting, and that makes it easy. But we might need to kind of ask the next question. And I kind of think about, asking the next question, and then ask the next question, and then ask the next question, and then kind of, okay, then you can move on, But sometimes we just need to give them that moment to do that. And to be perfectly honest, if you give them 15 minutes to do this, you've provided the care that they needed in a lot of cases, even if you did nothing. 30% of those people in that Indiana University study who had the placebo hearing aids also wanted to keep them. But they were fit by the audiologist who talked to them about their communication challenges and things that were going on, right? If you give them that 15 minutes, you have actually provided care to them that they otherwise would not have had. There is no other professional who will understand this enough to actually provide a useful ear to hear them. And there's no other professional who's going to give them the time and space to talk about this specific thing. There aren't any. When I was I actually was at a conference for the NASEM when they were talking about over-the-counter hearing aids, and there was a doctor, a primary care physician from the University of Michigan who was presenting. And he was presenting as a practitioner who was deaf. He had cochlear implants, and he had a translator, okay, so an ASL translator. And he told this group of people who were on the committee that, no, I do not have time to talk to people about their hearing loss. I understand that it's important, but I don't have time. My job is to make sure that their blood sugar is appropriate, that their cholesterol is taken care of. I'm trying to keep these people alive. I do not have time to talk to them about their hearing loss. So that to me was like, yep, nobody's going to listen to somebody with hearing loss except for us, or at least understand it, right? So that 15 minutes, 10, 15 minutes that you give to them is probably going to be one of the most therapeutic things that's ever happened to them, is really just getting to the bottom of them. That said, if it's a challenge, there are tools that are out there. So again, we've tried to develop some things to try to help with this. So there is a counseling tool that we have available, just about, let's talk about what your needs are. And this is based on some person-centered care techniques that have been developed, again, kind of globally. And when I mean globally, but also across other areas of medicine. So there's a few different types of questions that you can ask to try to help people, prompt them to really understand, be able to talk. Because again, some people are going to just come in and tell you everything. You don't need any of this. But some people are going to be a little bit more reluctant, so a little bit structured technique might help them to open up a bit. So one thing is really about how important is it for you to improve your hearing in a situation. So they can actually mark this on the line and mark it themselves. And that physical act of doing that actually makes them commit to, okay, this is where I would mark that. And then you can follow up with, why did you choose that number? Tell me more about that, right? And then you can also ask them about, how difficult is it for you in those situations? So you're talking about a few different things. One is how difficult is it for you, but then also how important it is. How is it to you, right? And so we've actually put together a few different types of scenarios. Again, it's sort of things that could jog their thinking about it, right? It's not there to be the perfect answer to anything, but just some things to consider. We also actually created it as a tear-off pad. So we have got the one that you could kind of put in front of them to talk about, but then there's one that they can actually go through and use it as a worksheet themselves, mark on the line why, how important is this to you? They can, choose the ones that are most important. They can put notes in there. And that's something that they could use then to go and, talk to their significant other, whoever, about it as well. So I think that there's a lot of value in them actually participating, like physically, in creating that if it's possible and it makes sense. Oops, I'm going to kind of come back to some of this. Okay, so next step, once we've kind of worked out, like, what's the problem here, right, is setting some meaningful goals. And when I say meaningful goals, I'm like thinking big picture goals. So not the objectives that we're going to get to in a second, but like, what does better look like, right? What if you could make this hearing loss go away, what would be different in your life? What would have changed, right? And I can't take your hearing loss away, but what is the impact and what would it look like if you had everything you wanted with regard to this, right? Like, get them to think kind of big picture. And once they've done that, then we can start to kind of break down that what does perfect look like into some things that might get us closer to that, right? But understanding their hopes and dreams is part of understanding their problems too, because again, if they haven't articulated it again, understanding what does great look like, what is our best outcome look like, might also help us to get a little bit closer to that too. So you can break these into objectives, and I think this is the part where it becomes really impactful to patients from a value point of view that's explicit. All the part that we've done up to now is incredibly impactful to the patient, but it's not as explicit to them, right? Because they're not thinking like, oh, you listened to me because I'm paying you as a provider to provide this wonderful service. They're thinking, oh, you're a caring human being who's asking me about this, right? But it is part of what they're paying for. Your time and your skill and in providing this empathetic situation for them is a huge part of what they're paying for, but they're not going to think about it that way, right? The part that they're going to think about in terms of, oh, this is what I'm paying for from a professional service point of view is actually going to be the objectives here. And where you're going to say, okay, this is what we need to work on then, right? Based on what you're telling me, let's think about it this way. What do we want to see happen? And so you can create these objectives. And if you haven't heard this before, SMART objectives are a really nice way to just kind of think about what would I want to put in there. It doesn't have to be this way, but it is nice if it can be measurable and specific, because then the person has to be concrete about it, right? So I want to hear the TV better. Okay, I want to hear the TV better, but when, what's the most important thing? What's your favorite show that you want to watch that's most important to you, or where do you have the biggest problem? Well, we watch Wheel of Fortune, and that's always an issue. I can't, or maybe was it Wheel of Fortune is the one with the letters, right? Yeah, so I can't hear those letters really well, right? And then I'm asking my husband, and he's giving me a, right? So, okay, so when you're watching Wheel of Fortune, you want to not have your husband be mad at you for turning the TV up too much, or for you, or that you're asking too many things about the letters, right? So, okay, so we're going to put it really specific, and maybe you want to make it so you're not asking at all. Maybe you want it to, be more comfortable, a different volume, whatever it is, right? And so you want to be like, is it achievable? You want it to be a realistic goal, and something that we can actually look at some moment in time in the future, right? So if you can be concrete, then what's going to be helpful is later on you can go back and go, what did that look like? How did Wheel of Fortune go with your husband in this room at this time? And they can actually give you a very concrete answer. When it's not specific enough, it becomes very difficult for them to actually give you an answer. And that's when they come back and they're like, and you're like, how did it go? And they're like, great, but, right? And then it's something completely unrelated to why they came in to begin with. When you actually can go back and measure these things and be really specific, they can really see the value then of what we've done for them. All right. One way to go about documenting this would be using the COSI. So if you're not familiar with it, the COSI is the Client-Oriented Scale of Improvement. It's a validated outcome measure, but I think it's really useful as a treatment planning tool as well. And so this is available in NOAA. So if you go under your questionnaire modules in NOAA, the COSI is right there. And so that's one place that you could do this. Now you could design your own treatment planning tool and put this anywhere else that you want it to be. But if you do want to have some place to document those and you don't, and you want a starting place, the COSI is a really good way to do that. And what you would do is in there you can actually go in and define what the specific needs are. They've listed it as a specific need, and that's how they've talked about it. But what I would actually do is turn that specific need of I want to hear better on the TV to I want to hear better, and by better I mean I want my husband to not get mad while I'm watching Wheel of Fortune because I'm not turning up the TV too loud, nor am I having to ask excessively about what the letters were when we are in the living room watching it, so that you have a really explicit goal in mind or objective in mind there. And you can put those in there. You can rank them. In order of importance, like, okay, so you've mentioned these three really big things. Which one's the most important to you, right? Which one, they're all important, but, if we had to say, like, this is the most important thing, which is that going to be? Because we want to know, there are some times where we have to make compromises, right, in what patients' preferences are versus what their needs are. And so we want to know, what is the most important to you? And then, of course, there it goes, we're on to then making recommendations, selecting appropriate intervention. And intervention means many different things, right? So this could be a tinnitus intervention, this could be cochlear implants, this could be bone conduction devices, this could be hearing aids, this could be, nothing. This could be all sorts of things, right? Could be counseling, could be auditory training. Whatever it is that is going to be beneficial to this person, we can include that as part of the intervention. So we want to be thinking about this as a holistic strategy to meet their objectives and their goals and do the job. So when it comes to that, if you are choosing hearing devices, hearing aids, again, we've created a tool to try to kind of help consider a few things. And basically, we've talked about this as preferences. So when it comes to somebody's diagnosis, their hearing loss, their communication disorder, their hearing disorder, the jobs that are needed to be done, you've already got a really good idea in your mind about where we need to go with this, right, from an audiologic perspective and a hearing care perspective. But there's also a whole bunch of other things associated with hearing aids that may or may not be absolutely related to that, right? And so I think it's worthwhile in a lot of cases to really ask them about their preferences, because they may have heard things about hearing aids from other people. They may have ideas going in about what's most important to them. And when we do have to make decisions about, like, do I go this way? Do I go that way? What devices am I going to choose? What technologies am I going to choose? We, a lot of times, are thinking about certain things. Some of those things are about our preferences in terms of the fitting. Some of them are about our own preferences about what we would want if we were using hearing aids. And so I think that in a lot of cases, we put our own biases onto other folks. And so again, the goal here is really making it explicit so that this is about a patient-centered communication. I want to know what's most important to you so that we can choose the technology that's going to work best for you. And so there's a few different options on here you can see. And again, you can do something like this. You can make your own. But, is clarity of devices important to you? The sound quality, reliability. There's a lot of people who are worried about that. Durability, appearance. There's a lot of people who are very concerned about that. And some people aren't at all. Right? Some people want to be able to have app access. Some people couldn't care less. Accessories, is this going to be an issue, right? Because if I want to hear the TV really well, that might be something that's important to me. Or maybe I can't use an accessory for some reason. I absolutely don't want it. Dexterity issues and connectivity. I see a lot of people go, well, they have this phone, so I'm going to do this, right? Do they care at all? It's a good question. And we did put budget on here very specifically. A lot of people are worried about that when they see this. They're like, well, everybody's going to say budget is important. I think to some extent everybody thinks, yeah, budget's important. The question is it the most important? Is it the least important? Or is it somewhere in between? How important is it relative to these other things? I think that is a really important component of what we should be talking to people about. And just put it out there very matter-of-factly. Where in the scheme of things does this matter to you? Because I want to make sure that I do what matters to you, right? Another tactic in here is potentially using technology demonstrations. I think this is really practice dependent. It's really dependent on the patient and sort of what opportunities you have to do this. Some people really love doing this and have a lot of opportunity for it. Others, it's not really a good match for their practice, but it can be useful, once we get to a certain point to be able to do that. Some people do it right after a hearing test, just to give them a sense of what devices are like. Whether or not that's the device they end up with, I think it's still worthwhile in some cases to just give them a sense of what the potential is there. All right. One thing that I think is challenging for a lot of folks is the idea of, what do we put in front of them? We want to make this decision about the patient. We want them to make these decisions. At the same time, we do have to be concerned about what is known as the paradox of choices. There is a psychologist, Barry Schwartz, who wrote a book entitled Paradox of Choice, and he lays out some really good research that was done on this topic. And the initial research that he talks about was that they were selling jams in the store. And they did a research experiment, and so they had people, doing the samples in the store. And in one case, they had 3 samples of jellies out there for people to try. And then the next time they went out and they had 7. And at some point they had like 26 available. People bought more when it was the smallest number of choices available. And in that case, and you don't want to take away all choice, right? But what you wanted to do was to put something in front of them that didn't paralyze them from making a decision. Because there are a lot of situations where if you put too many choices in front of somebody, it can cause them to freeze up and not move forward, with a decision. And so we, as healthcare providers, have to be careful that we don't put too much on the patient in terms of that decision-making ability. We need to kind of synthesize everything they've told us, take in all of that good information that they've given us, and then be really thoughtful about putting the appropriate number of choices in front of them to allow them to be able to make a decision effectively, knowing that if we do too many, we will necessarily shut them down in a lot of cases. His additional research went on to demonstrate that, in fact, if you give people too many choices, even if they do make a decision, in a lot of cases, they are not as satisfied with their choice simply because they had more choices available. Because there's a lot of people who just feel that in trying to, and some people are like okay with a good enough choice. There is a personality component to it, so this isn't the case with everybody. But so some people were like, it's okay, I made a good choice and I'm happy with that. There are people who are like that. There are also some of us, and you might be one of those people, where you want to make the best possible choice. And if you have that mindset and you put too many choices in front of somebody, they are likely to be unhappy with what they've chosen because they're not sure if something else would have been better. And so that's something that we have to be thinking about and just be thoughtful about putting in front of somebody what we've sort of curated based upon, again, their discussion with us already. That if we have been really thoughtful and listening and really gathered enough information from them, then we can feel comfortable that we're doing the right thing by putting a more limited number of choices in front of them so that they have enough to make a decision, but at the same time they're not overwhelmed and that they're ultimately satisfied with their choice. When we do make that recommendation, I think it's a great time to step back and go, okay, so this is my recommendation. How do you feel about this? And then you got to shut up for a second because they don't know, right? I mean, and they might not have thought that you were going to ask them that. So it's going to take a second. Sometimes they won't. Yeah, I'm okay. Gosh, I don't know. I'm still just really nervous about it. I'm not sure. I'm not sure how I'm going to pay for it. I don't know what my wife's going to think about it. The thing is, and some people are afraid when they say those things, they're afraid to hear sort of reservations if somebody has them. The fact is, though, if they have their reservations, they have it whether you've asked them or not. okay? But giving them the opportunity for them to say, yes, I feel this way. I get that. This is a big decision. And that's okay. And then we can move on because they've had the opportunity to express this. You can also ask them things like, how confident are your ability, how confident are you that this is going to work for you? Gosh, I don't know. I'm not sure. Tell me more about that. What are your concerns? What do you think might be an issue here? Because again, we're trying to confront these things on the front end to let them get it out. And do you foresee any barriers that we should address now? Is there anything I can do now to help with what you think might be a challenge? Yeah, I'm not sure if I'm going to be able to remember all of these things. I'm not sure where I'm going to plug this in. I'm not sure how this is going to work when I do blah, 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 right? Let's talk about it, right? So let's give them the opportunity to tell us how they're feeling about this. And then, of course, you want to establish progress metrics, which I think sounds more sciencey than it needs to be. But the idea is that you just want to see how they're going, right? But if you have done the treatment plan, if you've created the objectives, you have what you're looking for there. So in the COSI, again, you've got your opportunity to put some objectives in here. This was designed, though, as an outcome measure. And so you can look at how they've done it here, which is degree of change and then final ability. So degree of change, they've listed as, because of the new hearing instrument, I can now hear da-da-da-da-da. So it's like worse, better, worse, no different, slightly better, better, much better. That's one way to do it. You could do it differently, right? It also has a final ability. I can hear satisfactorily 10% of the time, 25%, whatever it is. But what I would say is it's never a final ability. It's a progress metric. Hearing loss is a chronic disorder. It's not going to get better for the vast majority of people, right? And so we have to be thinking about where are they on their journey. And so there really is no final ability. So, I'd say if you're going to use it this way, this is for you as a metric. But it gives you something to think about and a way to think about it. But even if you don't quantify where they are, the fact that you said, so how did it go watching Wheel of Fortune with your husband, da-da-da-da-da? Were you having to turn up the TV? How did it go with the letters? What was your experience? How did you feel about it? How did he seem to feel about it? Just ask that question about the objective. You can just write down a qualitative answer, okay? That's the same thing. It doesn't have to be measurable in this way. It's qualitatively measurable. They know it when they see it. They know if it's better or not. They know if it's where they want it to be or not. But because it's concrete, it's much more specific and measurable. And so that's, I think, where you can get really showing the benefit of the treatment and really focusing them on what was most important to them. And then reviewing and adjusting as needed. So they might say, hey, this has been great. I have a new problem, right? Something else has come up. You can see a kid for years. I think Kathy had it was educational, right? You can see a kid for years. They go off to college. They come back. I have a new problem, right? I can't hear in this classroom with this teacher. Okay, let's address that, right? I had a patient who I saw who had a collapsed ear canal. He had a mastoidectomy when he was 3 years old. I met him when he was 83, collapsed ear canal, all sorts of stuff going on. We got a really good solution for him for 3 years. And then he woke up one day and the ear that he had a hearing aid in, all of a sudden he had a sudden sensorineural hearing loss in that ear. Boom, gone. Great, now I have to deal with the collapsed ear canal instead. So we have to start all over again, back at the beginning with the diagnosis because, and my little arrow, you're gonna go all the way back to the beginning, right? Because now we've got a new issue, something else has happened. And for your patients, it might not be a whole new otologic issue. It could be that they had a stroke, right? It could be that their spouse passed away and now their communication needs have suddenly changed. It could be that they want new technology because they lost their hearing aids. What do I want to see differently this time? What didn't I have before that I want to have something new happening, And so there's a lot that we can do, just it's a chronic situation, and so we can be constantly thinking about what are we going to do next. So that review and adjust as needed sort of takes us back to the beginning. So, there's a lot of proven benefits of person-centered care. From a clinician point of view, all the research has supported this. This isn't specific to hearing care. It's general across all of medicine. But basically, you have, as a clinician, you're improving your communication skills. So this isn't just for once you start having these deep conversations, it turns out you don't just turn it off, right? You can have these better conversations with your employees, with everybody else around you too, while we're practicing it. But you oftentimes will have increased engagement, when you have that depth with a patient. And so I think it's beneficial to us as clinicians. And what we've seen is, in other areas of medicine where this is applied, there's greater job satisfaction and less burnout. From a service outcome, it's just easier. Things go better when your patient knows you care about them. I mean, we had a guy who was at Henry Ford, and his name was Bill Dickinson, and he was at Phonak for a little while, actually, after he left Henry Ford. But patients, I didn't even work with him, and I was there 5, 6, 7 years later, and people are like, did you work with Bill Dickinson? I'm like, yes, I worked with Bill. I didn't work with Bill, but I know of him. And apparently he would run hours behind, and patients would be like, it's fine. I'm happy, I'll wait. Whatever Dr. Bill needs, I'm just here waiting for him, because he took the time with the patients, but they knew that he was taking the time with the patient before them, and it threw off everybody's schedule. All the front desk staff were ticked off and everything, and the ENT doctors were all mad, but the patients would do anything, would wait forever, because it was Dr. Bill, and he cared about them, right? When you've established that relationship, they're not gonna turn around and go somewhere else. They're going to be your patient, right? Are there some patients where cost is the most important thing to them, and maybe they don't value the care as much? Okay, that's fine. And maybe they're not your patient, right? But when you've listened to them, they're almost always going to be coming back to you. The other thing is higher employee retention. When your employees are satisfied because everybody's happy, that makes it a lot easier to carry on your practice. In terms of patient, of course, you can imagine that there's a lot of really good patient outcomes with this, because they just have a lot of good experience knowing that they're cared for. And of course, then they're going to be much better advocates, and be sending a lot of patients, other people to your practice. Just a couple of tactics, again, to try to help strengthen your abilities in this area. Cultural differences. Very multicultural society, right? And we want to make sure that we're taking care of everyone. ASHA's website has a really nice cultural competency checklist and some resources available. And so that's something that you might be interested in if it's not something you've thought about, in order to be, again, more patient-centered. And then the other thing to just be keeping in mind is healthcare literacy. And so that means a lot of different things, but a lot of times we want to put materials, again, in front of patients. And we have to recognize that the average American reads at 7th to 8th grade level. When we create materials, we want to be trying to adjust them for that. And so it's important that, we kind of be thinking about that when, again, the language that we use with patients and so on, to make sure that we're meeting their needs. So with that, I want to stop here, and I don't know if there was time for, I think I still have 5 minutes. Yeah, okay. So if there's questions or comments or things you would want to share about your experiences from within the room, I think is where we're starting. And I don't know if there's anything online or not.
I just checked.
Okay.
If there are any questions online, am I confirmed? Yeah? Okay, no questions online. Any questions from the live audience? No. Question.
I just have a comment, not really a question. I think what you introduced is kind of quite evocative in the sense that if we compare ourselves to speech pathologists.
Would you mind? Sorry, I'm sorry. Yeah, thank you.
I was just saying that when you presented. Can you hear me?
No, he's going to turn on.
Oh, okay.
There we go. Thank you.
So I was just going to say that what you presented is quite evocative, because if we compare ourselves to other speech pathologists, right, when they do their therapy, their thing, it just looks like they're just playing with a kid, right? And then the parents are just paying thousands of dollars, hundreds of dollars, right? But then they compose this therapy plan, right? With objectives and what you just presented and rationales and 1, 2, 3, 4, 5, and then they stamp their, their name and their license, and versus what do? We stamp our name on the contract instead with,
Yeah.
with the prices of the hearing aids, right?
Yeah.
So in terms of the medical view, that's quite an interesting concept. It's just going to be a barrier trying to, somewhat sell that, for lack of a better word, with your employer, because obviously taking the time to write things out, type things out, right?
Yep.
Typing out the goals, but it's definitely more medicine focused, which is nice.
Yeah, yeah. Appreciate that. Yeah, thanks. And I think that's, that's part of why we developed the tools that we did, was to try to say, okay, are there some shortcuts that we could take here? Are there ways to make it a little bit easier to implement? But I think there's always baby steps too, right? So kind of maybe think about that one place that you could start and put that into your documentation, right? Or think about it, where, what am I already doing, right? Which is kind of nice to take stock of, okay, I'm already doing this. And I think a lot of it is we are already doing a lot of this. It's just that we're doing it up here. And when we're doing it up here, it's like the speech language pathologist they're just playing with the kid, right? Because nobody's seen what they're thinking about in terms of, they're trying to get them to do this. This is my object. This is what I'm trying to do. I have a strategy up here that I'm executing upon, and nobody sees that, right? But unless they make it explicit, and that's all the sort of putting this down in front of them is making it explicit. But that's where the objectives, I think, come into play. Yeah, and it does take more time to do that, but I think that in the long run, I think especially for employers, it's kind of like, let me try this, or even try it. Sometimes I'm like, do it with the first patient of the day, right? Even if it's not, when you have the most energy and stuff, do it with that first person and just do that for a month, right? First person of the day. And all of a sudden it's like, oh, I'm starting to see some benefit from this. And actually, in the long run, it kind of speeds things up. And actually, I might not need as many follow-up appointments if I've actually addressed their concerns because we articulated them, And so then it just becomes a little bit more muscle memory, right? And then it becomes faster and easier. I used to do that we'd have students come in and it was like, they don't know how to do reflexes. And I'm like, focus on one thing, do that one thing, right? And then move on to the next thing. You don't have to learn to do everything all in one day. Just do one little thing at a time, or in bits like that. So that might be one way to think about it, yeah. Okay. Oh, there's a question online?
Yes, there's a couple or 2 questions. So one person is wondering if the Oticon forms are downloadable online or accessible in some sort of way.
Yes, and we can include forms, yeah.
We have some at the table
Yeah.
here, and we do have PDFs, so if you can tell us their name, we can send them the PDFs.
Yep.
Could you repeat that through the mic?
Yes, I'm sorry. Yes, thank you. Yes, so we do have the PDFs of them, and we can absolutely send them. And so if you, I don't know what's the best way if we have their email addresses or the name, we could find the emails to get them.
Email address in the Q&A? Yeah.
Q&A, okay, perfect, thank you.
Another question is, can you estimate the amount of time and patient's flow for adding some of these services in a busy audiology or ENT clinic?
Yeah, and again, that's going to be really practice dependent, right? Because again, how much of this are you already doing is part of the question. But I would approach it in that way, right? Sort of try out what you think is going to be the most impactful, but least of the smallest speed bump thing to try out. Do it a little bit at a time, do it with that first patient of the day, and experiment and find out what does work best for your clinic, for your patient flow. And you don't have to do it all at once in a single day. Try a little bit at a time. Great. Yes.
Your thoughts on this, Virginia?
Yeah.
I do feel like the counseling tool is nice.
Here, I can get this. Here, sorry.
Sorry.
Online can't hear the people in the audience unless they talk in a microphone.
Got it. Thank you. Sorry, everyone. I was just saying, I want your opinion on this too, Virginia, but I feel like the counseling tool is nice because it helps get your patients thinking about their hearing loss. To your point, a lot of times people don't really think of their hearing loss until it's an issue, right? Until they're sitting in front of you and you're starting to ask those very kind of basic questions to get them thinking about it. So I often wonder if it's almost a way to alleviate and shorten that time by getting them to think about the details of their hearing loss and how they experience it. So, and if you're focused on, the environments that are their goals, that can also help move that conversation along a little bit too, in my opinion. But
Yeah, I think it's like really recognizing and empathizing with what they're going through, right? Because again, I don't know that we're going to get them any sooner than they're going to get in. Like, I think it's only when they have that major problem that they're just like, I give up. I have to do something. That's when they're coming to see us, right? So I think that, but being empathetic, and helping them to understand, I get it. We can do something about this, but like we really need to get the emotional engagement. I think if you can get the emotional engagement, that does move them along faster, right? Because now they're committed, because they have some skin in the game, because they've explained all of this, right? So I think it's that emotional engagement because what we're doing is we're not just selling something. This is behavioral change. They got to get up every day and put that thing on. They have to actually use the devices. And if they're not going to use them, they're going to bring them back, and they're going to like not have a good experience and not be recommending people to come to your practice and so on. So if we want them to actually implement the behavioral change that goes along with using devices, not just getting devices, then we have to have the emotional engagement. And I think that that's where the questions come in and, the discussion.
I think also, Virginia, we need to do a lot more encouragement in follow-up appointments. So, for instance, I had someone come in the other day, and she said, "Gee, I don't know how well they're doing." I said, "Well, one of the things we talked about, how are you doing in Mahjong?" "Oh, I heard good in Mahjong." I said, "Okay." I said, "That's a big thing." I said, "How'd you do in church?" "Oh, I finally heard in church." So sometimes you have to point out the things that you had discussed earlier. And sometimes with the newer technology, just because I'm so old, but sometimes with the newer technology, they don't see like immediate benefit because it's so natural sounding. And so to them, it's like, oh, I'm hearing things, but they're not cognizant of the fact that maybe they weren't hearing it before. So encouragement and pointing out these things is very important in follow-up.
And I think those examples you gave are really like, if you can put those down in writing, that the Mahjong, right? This is what I want to hear better, right? In church and this and that. That's a really good way to do it. And it's like, and I bet you probably, if you haven't written it down, like some of us, like I'm not one of those people. I'm not one of those people who would remember those things. I can never remember anybody's name. It's horrible. But there's some people, some clinicians who are like, remember everything from the conversation and could come back and do that. But if you're like me and you don't, you're not going to remember to ask about those things. Or in some cases, they end up seeing a different provider. They have no idea, right? So if you have a new provider that they're seeing, they can come in and actually ask about those things when they've been written down. So I think it's exactly the same idea, right? That you just turn what they needed into that objective, and then you can show them the clear benefit. Yeah, absolutely. All right, well, thank you very much. I know we have another speaker coming up here.